FP agonists bind to FP receptor, which can increase intracellular calcium ion. In contrast, EP2 agonist omidenepag can bind to EP2, leading to the increase of cyclic MP. So it means the cellular signal is completely different. Omidenepag is a selective EP2 agonist. It doesn't have a prostaglandin skeleton in the chemical structure, and it binds only to EP2 receptor, not to bind to FP receptors. Omidenepag increases aqueous humor outflow by both uvascular and trabecular pathways. So this mechanism of action is new and proven using the ocular hypertensive monkeys. I will show some clinical studies. So one is IAME study. So this is multi-center randomized later masked parallel group comparative study. The patient was allocated into two groups and treated with omidenepag or latonprost. After 4 weeks, the omidenepag demonstrated non-inferior IOP lowering effect compared to latonprost. So this is the first drug in point of IOP lowering effect comparable to latonprost since it was launched 20 years ago. The next, so this is a long-term study, multi-center open label parallel group, and followed up for 52 weeks. The patient was divided into two groups with low IOP groups and high baseline groups. The patients were treated with only omidenepag in low IOP groups and high IOP group, and also in high IOP groups, the patient was treated with omidenepag and timolol concomitantly. After following up 52 weeks, in the low baseline groups, omidenepag can reduce IOP 19.5%, 3.66 millimercuries. In high baseline groups, omidenepag can reduce IOP 23.4%, 5.64 millimercuries. And also in the high baseline groups treated with omidenepag and timolol, the IOP reduction was 36.1%. In all visits, omidenepag significantly lowered the pressure. So one of the characters of EP2 agonist has no cosmetic side effect. So as you can see here, this patient indicates dews and complained her cosmetic changes after long time use of FP agonist. So we switched the FP agonist to omidenepag, and in one month and 3 months, her dews completely recovered and improved. Omidenepag treatment has a benefit to recover paths after switching from FP agonist without changing IOP. EP2 agonist can maintain quality of life and quality of vision. Omidenepag isopropyl is the only drug showing a comparable IOP lowering effect to latonprost, and sustainable IOP lowering effect by increasing outflow with once daily administration. And the ocular side effects profile is different from FP agonist, excluding hyperemia, and the other adverse reactions are thickening of cornea, cystoid macular edema, and iliitis. And omidenepag doesn't have cosmetic side effects such as PAP with FP agonists. So these data indicates we recommend EP2 agonist for the first line drug, especially for first eye drop for glaucoma treatment, young women, and treatment only for one eye, and patients with severe cosmetic side effects associated with FP agonists. So next I will show ROCK inhibitors. Now we have two kinds of ROCK inhibitors. One is Ripasgil 0.4% twice daily use by Kowa Pharmaceutical Japan. And another is the Netarosgil 0.02% once daily use by Eli Santen Pharmaceuticals. ROCK inhibitors directly improve trabecular outflow. So as you can see here, in the POAG, the trabecular meshwork outflow pathway become compact. However, by using the ROCK inhibitors, the space for trabecular outflow increase. The mechanisms are many. So one is the change of cytoskeleton and contraction of trabecular meshwork